afternoon. Yes, you're audible.
Hi, good afternoon, everyone. I'm very happy to welcome you all to this session. Today is the day for Sexual and Reproductive Health Awareness Day, and I'm very happy to have you all here in this session today. And above all, I'm very happy to have an all-female panel today, which is very exciting, of course. Okay, so on behalf of Fair India Academy, we are conducting this webinar on crisis to care, enhancing sexual and reproductive health in disaster management. So disasters and emergencies, as we know, will significantly impact public health systems and often disrupt sexual and reproductive health services. And women and children being particularly vulnerable, they face immense challenge in accessing critical health care, right from safe childbirth and family planning to preventing sexually transmitted infections and gender-based violence, especially in the shelter setups during disaster times. And there are a lot of global guidelines that exist, but there is gaps in service delivery, and that is to be particularly discussed today. And so we are bringing together three experts that are going to discuss about the importance of integrating SRH services into disaster response. Field experiences, logistical challenges will also be discussed, and research will also be touched upon to look at the way forward. In this session, we are trying to bring about some recommendations as well and strategies from the experts themselves that has had experience in this. And we are very excited and we look forward to the session. We would request all the participants to have an interactive session and feel free to ask us any questions. You can drop them in the chat box or wait for the Q&A session to begin in the end of the session. And now that we go into the session, so first topic is integrating SRH into disaster risk management. We would like to jump upon directly on the disaster part of it. And for that, we have Dr. Shilpi Das from ADRA India. And I am very happy to have Dr. Shilpi having a very rich public health experience, and a health person coming into the conversation is very nice. Dr. Shilpi is an accomplished public health professional. She has over 15 years of experience in the field. Madam has experience working with esteemed institutions, including the NCDC, that is the National Center for Disease Control, and the Department of Biotechnology, Evidence Action, and Bush Foundation. He is presently working with ADRA India as Senior Manager, Programs, Operations, and Strategies. Her areas of expertise include the disease surveillance, strategic planning and implementation, project conceptualization, and capacity building. With experience in both the livelihood and health sector, she has effectively integrated these areas to promote a holistic approach for community well-being. Madam is a good inspiration for me, a person coming from public health itself into the disaster management field. I welcome you, ma'am.
Thank you, Krupa. Am I audible?
Yes, you are very clearly audible.
So thank you. Can I just share my screen?
Yes, you can do it. I think you are co-host
Let
now.
me know if it's shared.
Yes, you can do it, ma'am. Can you please turn it to presentation so I'll confirm it before giving it over to you? Yes.
Is it okay?
It's clear and visible, ma'am. Yes. Great. Thank you. Over to you.
Thank you. So thank you, Krupa, for the brief introduction and giving me an opportunity actually to talk about this important topic about integrating SRH, the sexual reproductive health, into disaster risk management. So I am, frankly, if you ask, I am a health person and I'm not very much into disaster, but yes, I have been with ADRA, a disaster response humanitarian organization. I have seen the impact which the women and the children are facing during the disasters. So when emergencies and large-scale disaster happen, there is a significant impact on public health, health infrastructure, and the delivery of healthcare, of course. And economic losses from these events run into billions of dollars. And unfortunately, when emergencies happen, the most who are impacted are the poor and the most vulnerable, particularly women and children. India is endemic for diseases like tuberculosis, HIV, vector-borne diseases, malaria, dengue, and in crowded places during disaster, a significant proportion of people get impacted. In addition, due to the already weak system, emergencies linked to displacement, food insecurity, and poverty increases vulnerability to these diseases and, of course, negatively impact lives. Now, these sexual and reproductive health services are important for women during disaster because they can impact the maternal and the maternal, infant, neonatal morbidity and the mortality rate. This is very important for any country. The denominators of maternal mortality and should be low, basically. But this really impacts when these SRH are not taken care of. Neglecting can lead to serious consequences, including unsafe abortions, sexual violences, reproductive morbidity, and mental health problems. Now, this particular slide depicts the challenges women face in disaster. So, women are, of course, more impacted due to the pre-existing gender inequalities, and especially even more when they are from the lower socioeconomic group, just that I have already mentioned above. The reason, of course, for this vulnerability can often be traced to the roles females play in society and existing gender and cultural norms where they live, basically. So, disaster do impact access to other resources like wash facility, nutrition, giving additional burden to women during their monthly menstrual cycle days. Economic dependency is more for the woman. There is societal expectations from the woman and increase vulnerability to violence are of course there during these challenging times of disaster. So what do we do? So a multidisciplinary disaster management system to address the sexual reproductive health during a disaster would involve a coordinated effort. Without a coordinated effort, this is difficult to achieve. And various sectors like the healthcare, social services, gender equality advocates, and emergency management with a focus of providing accessible, safe, and good SRH services throughout the disaster cycle. And this would include basically prevention, preparedness, response, and recovery. Response and recovery phase tailored to the specific need of affected population, particularly women and children, basically. And by incorporating this consideration into a comprehensive disaster management system, communities we feel can better address the unique needs of women and girls during this period. Now, when we are talking about a multi-sectoral and multidisciplinary health emergencies and disaster risk management system to protect the public health system, some measures has to be taken and to build the resilience of health system to emergencies and disaster. Now, how do we do it and what are the systems which can be taken care of? One, I would say that incorporate the sexual reproductive health into multi-sectoral and health emergency risk management plan at local level. Basically, allocate funds, allocate financial resource to human to integrate these SRH into the national health emergency risk management program and in emergency responses and recovery plan. The other would be to integrate the sexual reproductive health into health risk assessment and provide early warning. This can be kind of a prevention. Estimate the impact of identified SRHs, like what is the vulnerable population, what is the percentage of women who are pregnant, what is the excess of vehicles if the women are delivering or have gynec problem or need newborn complications. So this has to be measured to strengthen the overall primary healthcare system and plan for emergency response to address this concern. We have to create an environment basically of learning and awareness to address some of the risk and actions for improving the community health safety and resilience at all levels. Now, the other thing which is to be done is networking, like community networking to monitor local vulnerabilities and capacities, build on local facilities to withstand local hazards, and to ensure that basically these facilities remain functional during the SRH services, which includes the childbirth, the obstetrics, and the newborn complications during emergency. How do we handle that? That has to be measured, that has to be mapped before any emergencies. Uh, Prepare existing services to absorb the impact. If any emergency is we are forecasting, then there should be a way to absorb the impact, adapt, respond to, and recovery from the emergencies. Basically, we can pre-position reproductive health kits, maintain vehicle to be used for referrals of complications, and have clear policies and guidelines through a well-coordinated response. For ADRA India, if you ask, we have a basically during the emergency, because we are working in Assam, Northeast, it's a flood-prone area. So before the emergency, we know in fact it's a flood-prone area, the timing, when the flood will be coming. So what we do is the SAGs who are running the sentry napkin are basically, they are prepositions before the flood, and they are activated to work for increased production of sentry napkin to support during the emergency kits. One of the important thing which I would like to highlight here, and which not many organizations are doing, is the psychosocial support which has to be provided to women and children during the disaster and post-disaster. So before the disaster, we should be prepared for the recovery phase also. Specific sessions should to be taken, especially for the children and the women, focusing on their mental health, their nutrition needs, and the psychosocial support. So I think these are some of the important points as a health person I would suggest for disaster management, in which can be a collective effort to reduce the impact of disaster and save life. Uh, Thank you. That's all from my side. Over to you, Krupa, for I'm open for any questions. Happy to answer any responses.
Thank you, ma'am. Thank you for the presentation. I am very happy that we could touch about the unsafe abortions that happens if the SRH services are not delivered properly. And thank you for giving us the Assam model of ADRA, and hopefully, like how you said, SRH to be included in the policies and all. We hope that Assam model is extended nationally, and yes, and that is a good thing that we discussed upon. Ma'am, would you like to take questions now, or would you like to wait for the Q&A session?
No, I think I would like to take questions because I have another meeting, Krupa. So I
Yes,
think there
that's
is
why
some
I asked.
hand
Yes,
raised. Yeah.
a hand raised. Richa, you can ask your question. I think you should be able to unmute yourself.
Yeah, thank you, Dr. Shilpi, for the quick and very clear presentation. I was wondering if you have considered option of introducing menstrual cups to the communities, because I'm seeing there is a lot of focus emphasis on the sanitary napkins provision, but whether you have considered a menstrual cup as a model. I understand in disaster situation, again, access to good clean water is definitely an issue, but maybe this can be thought about, just a suggestion or any experience towards that end. That will be helpful. Thank you.
Yeah, thank you, Richa. If I'm, yeah, I think you're Richa. Yeah, thank you for this question, and I think this is a very apt question. Frankly, if you ask, we haven't tried that in our area of operations, but as a technical person, we would really like to promote the uses of menstruation cup. But there are studies which says that still there are hesitation even in the urban areas of using menstruation cups. So when we are talking about disaster, the most vulnerable, the socio, the where there is a challenge in the socio-economic, we really have to understand their capacity to and their acceptance for using the menstruation cup. So I think this is something which need deeper understanding, deeper also maybe a research to understand the acceptance of menstruation cup among this strata after the disaster. But yes, if it is taken care of, I would really like to say that it should be promoted for sure.
Yeah. Thank you, Richa, for the question. I think talking about menstrual cups, we do want to include sustainable materials for service deliveries, yes. But like the goal is to reach more in the comfort and the widely accepted services and kits to be used is the huge goal here. There is another question. Is there any framework to assess vulnerability for women affected by disaster?
I'm not sure
Bhavana, I
if
think.
Yeah, Bhavna, yes. I'm not sure I'm the right person to answer that if there is a framework to access vulnerability for women. I think people who are already full-fledged into the disaster management would be a better person. But yes, from my understanding, there is a framework. But yes, on what level, I am not very sure about that. Yeah.
Thank you, ma'am, for touching upon also, since the question arose, thank you for also touching upon the risk assessment and identifying vulnerable groups in the community and in that before the time of an emergency. I think about this question and what we discussed, the next speaker, Ms. Sujata, will be able to
Yes.
brief a little
Yeah,
more
Yes.
that was
about that.
about to tap that. Yeah, it is
Yes,
there
we
in my
can.
slide.
Yes, so it's a good transition that we have from Shilpi ma'am's presentation to Ms. Sujata now. So thank you, Shilpi ma'am, for the presentation and answering the questions.
Thank you.
Yes, PPTs will be shared after the session to the participants. Over to Sujata ma'am now. Ma'am, please give me the honor of introducing you for a minute. If I can.
Yes.
Ms. Sujata Anishettar, Madam is a seasonal development professional with over 2 decades of experience in public health, social marketing, and community-based interventions. Ma'am holds a social work master's degree and is pursuing her PhD right now. And since joining FPI in 2000, she has held many roles, including impactful projects like Spandana and multiple CSR funded initiatives. Madam has contributed to research developing RCH training modules and presented papers at international conferences. She's an excellent organizer and trainer. Sujata ma'am has conducted capacity building programs for healthcare professionals, government officials, and grassroots workers, strengthening FPI outreach and impact. I am very happy to have you over, ma'am. Madam is a very sweet person I've met and talked. I'm very happy to have you here. Madam is going to cover 2 topics for us today. And thanks a lot for that, ma'am. Over to you.
Yeah, 1 minute. I will share the slides.
Ma'am, we can see your screen.
Krupa, will you share my slides?
Yes, ma'am, but
1
I'm
minute.
yet to receive it.
I've sent it. 1 minute, let me check.
Okay. Yes, ma'am, we can see it. Please change it to presentation mode. I'll confirm it.
Yeah. Yes.
Yes, it is visible, ma'am.
Yes. Thank you, Krupa, and good afternoon, everybody. So today I'll be discussing the challenges in identifying and addressing vulnerable population, especially for sexual and reproductive health service delivery during disasters. So, what are those challenges to identify also, like, and how we are going to address this one? So first, like, before me taking up the challenges, let us see like who are vulnerable. As she questioned, like, is there any framework to assess vulnerable population? See, by vulnerable are the people who are at risk, like example, pregnant women, lactating mothers, or adolescent girls, and women with pre-existing health conditions, with any health hazards and all, like cancer, it may be HIV, STIs. Then people with disabilities, sex workers, LGBTQ individuals, migrant population, and those who are living in the isolated areas. Mainly, these are the people we consider as vulnerable, and we have to take special care of these population during disasters. And why it makes them vulnerable also is like why we call these people as vulnerable is one because of the age. Age is like adolescent girls and boys, they become victim of like child abuse or anything, exploitation and all. and elderly also, because they need special care. Then gender and gender identities, like if you consider female, they are more vulnerable than men. And if you consider the general population versus LGBTQ, they are more vulnerable. So pregnancy status, breastfeeding status, and all. And if you see economic, socio-economic status is like, especially in these groups, again, vulnerable are with low income and those who don't have access to healthcare. And if there is a displacement due to disaster, if they are moved to any shelter homes or anywhere, or moved, migrated to other place, other state, district, whatever it is. And if you see the health condition, if there are any chronic diseases already existing in them, or HIV, mental health issues if they are suffering with. And if you see the social factors we call as marginalized communities, which may be the BPL population or below poverty line, then ethnic minorities, and those who lack the social support networks. And geographic location is remote areas. You can see some scattered homes will be there. From one house to other house, it will be a very far, or from the main area, the houses will be far. So in the remote areas or on the hilly regions, then disaster prone regions, if they are there, then these population are considered to be vulnerable. So coming to why the sexual and reproductive health needs, like these are the six things we have to uh, think of, like in disaster where we are giving services. One is to ensure the health sector cluster identifies an organization to lead the MISP, that is minimum initial service package for sexual and reproductive health. So we have to make sure that all the health clusters, they are priorly identified, the pre-prepared to give these services. Then prevent sexual violence. So one thing is like, how we are going to prevent the sexual violence to respond to the needs of the survivors. And we should be prepared to prevent the transmission and reduce morbidity and mortality due to HIV and other STIs. So we have to train all the people, right from the community, other service providers, private and government service providers, on the syndromic management of STIs, or it may be like not stopping the RT supply during crisis and all. And the fourth objective, we should see, make sure that we prevent excess maternal and newborn morbidity and mortality. That is like BMOC and EMOC, we tell that basic obstetric services we should be able to give, or emergency also, which also includes blood transfusion. Then we should also see that we prevent unintended pregnancies by timely supply of contraceptions. So there should not be any unmet need for the contraception. And we have to plan for comprehensive SRS services integrated into primary health care as soon as possible. So it should not become a standalone program by any CSO partner or any one partner or any one set of people. It should be comprehensively together coordinated efforts, so that when you withdraw, the still the program has to go on in the recovery phase also. And ensure that this is one more priority is included. After seeing at the COVID response and all, unsafe abortions increased drastically. So we should see that the abortion delay should not happen even during the disaster. So these are the things which are very important and very crucial during the time of disasters. All these objectives need to be met, and the pre-preparedness for these objectives is very much required. So what will be the challenges? What are the challenges, like if we are not meeting these things, like SRH service delivery is like, we have to first, one challenge is like we have observed whenever we implemented this SRH service after the disasters, like main is cultural sensitivity. So we have to respect cultural norms, practices while providing SRH services. We have to see that what are the cultural norms of LGBT people or pregnancy, like whatever, or from region to region it differs. So we have to identify their, regional cultural sensitivity needs. Accordingly, we should be prepared for providing the services. Then only the acceptability increase. So minimum initial service package for SRH is essential standard for all. It is not only standard for general population, it is for everyone, men, women, LGBTQ or elderly people, children, everyone. So, and reduce the vulnerability of at-risk population before an emergency occurs. So we should see that, like, how they are not, we should make sure that they are not stigmatized or discriminated when we make some camp settings or when we provide services. The people should not humiliate these people. So in that way, we should make sure that at early stage only pre-preparedness should happen to see that they are protected very well. And secondly, is like prevent and manage the consequences of sexual violence instead of giving room for more stigma and discrimination. So we should always see the preventive strategies. Like after happening of sexual violence, then it will be, lot of stigma arising in that group, or they may be thrown out from those camp settings. So that is why before in hand we have to be prepared to see that. But this is one of the biggest challenge of like how we are going to prevent consequences of sexual violence, because many strangers are together and they lack privacy and all those things. So this is one of the very big challenge to see that in disaster, like how we are going to manage this. And the next challenge is adopt specific policies for the inclusion of vulnerable population that reflect risk assessment, gender, and other analysis into disaster preparedness planning. So whenever any policies are prepared, we also should include the vulnerable population to be the part of this discussion. Otherwise, what happens is like we all often neglect the vulnerable population, and when we make any policies, then again lot of stigma and discrimination may happen during disaster for providing these SRH services. Involve vulnerable groups in the development. That's what I told. Like we have to involve to see the early warning symptoms and ensure their needs are addressed and the systems are gender responsive. And if you see why it is very important is most of the country, if you see 25% of the countries still don't have necessary laws or policies to combat sexual violence, to solve the problem of sexual violence. While if you see 1 in 3 women experience in the normal timings also experience physical or sexual violence at least once in their lifetime. So prevention, preparation and response to sexual violence as one of the need for reproductive health. This is very important point. We have to see that how we are going to prevent also. Then the preparation and response phase will come. Then raising public awareness is very important of dangerous behavior. So we have to like how we are educating our children on good touch and bad touch, how like immediately they should come and report, where they should come and report if there is any violence happening. So all those things should be given awareness to the public people so that they will immediately report the sexual violence, and letting those who are exposed to it also. Most of the time, we have to create an atmosphere or environment where they can come and report that they are the victims of the violence. So they should come and report in that way. A very friendly environment should be uh, laid down so that they'll come and report these things, and treatment they should receive. And about like what happens if they immediately report, then what is the treatment available? Everything should be known to the public. That is one of the great challenge, how we are giving this awareness for all the public before the disaster occurs or pre-preparedness in the pre-preparedness phase. Lack of knowledge of healthcare providers about the importance of cultural sensitivities in response to victims of sexual violence can prevent rape victims from reporting. If you see like one of the case I saw in like one girl was admitted in the health center, and she was not given service because the FIR has to be done. It was a POXO case. So we should make the healthcare providers very sensitive about this, like why there is a delay. So what is that sequence of care should take during disasters, and why they should first do this only and why not that. So we have to discuss and keep the healthcare providers ready with all the people together, see that the girl or a victim is given service without any stigma and discrimination, and with a very privacy and a confidentiality should be maintained for that client. So these are the cultural sensitivity is very important, and these are most of the challenges we face during service delivery of sexual and reproductive health. And privacy and confidentiality is one more very challenging thing we uh, came across while providing SRHs. Um, Provider bias represents significant barriers. If you see, if an unmarried girl comes and ask for MTP service, if a married girls against a married women, then there is lot of bias by the providers. So they should also be updated with the latest amendments, like how the 2021 of MTP amendment is there, that the married women, word has been replaced to partner, and the punishment is very serious if the privacy in the breach of privacy and confidentiality. All these things, the people should be knowing. Then only they are very much aware, and the provider bias reduces. And one side, if you see like privacy and confidentiality, one side keeping data is confidential, and on the other hand, in camp setting, they are expulsion of suspected women. So we keep so many times we keep the data confidential when they are coming for the health facilities in these normal times. But when they are in camp settings and all, if they are really known that she is particularly APL-HIV or any other sex worker, so there will be one of the thing is like, on the other hand, there will be lot of problem with revealing the confidentiality and the privacy of that particular client. So also we came across the challenges. They hesitate to go. Most of the time when we asked women and girls to move to the camp settings, they felt that they hesitated to go to the settlements due to the unethical behavior. So they told like, no, many strangers will be there, and my girl may be the victim of something else. So physical assaults may happen for women. Pregnant women may feel very deeply depressed, distressed, and all those things were reported for these camp settings. So we have to be very sensitive enough while designing the camp settings for such vulnerable people. So much importance has to be given to access of safe, private, and functional toilets. See, most of the time, in the disaster, they focus more on food, shelter, and clothing. They don't even think of like functional toilets are there, bathing facilities are properly done for women, and clean water supplies, as Richa she mentioned about menstrual cup. So, sanitary pad, if they want to change, there is no, well, we have to make sure there is proper water supply there. And third challenge is about the collaboration. If you see collaboration, working with like the government, uh, we have to see that we start working with the government for all these, because government alone also cannot take this whole disaster risk reduction, or the pre-preparedness recovery stage, or during post anything. So we have to make sure that the whole network is ready with the GOs, NGOs, public communities, and other health agencies to coordinate response efforts. So that, because and usually we have to see that in emergencies, the communities are the first responders. So we have to prepare the communities also as the first responders, and start the collaborative efforts. But most of the times we neglect, and uh, we make sure that only certain health facilities and government together and do this program. But raising voice from the community is very essential in this disaster time. Lack of community networks to monitor local vulnerabilities and capacities hinder to prevent, prepare, respond, and to recover from emergencies. So there are a lot of LBOs, Mahila Mandals, Youth Yuvaka Mandals. So they are the people who can raise voice on their behalf of their peers. Like it may be youths, like any youth is suffering from any abuse or anything. They are the person who should raise the voice. So we have to prepare them and build a community networks to monitor their own population, their own peers. Sufficient number of trained health workers and adequate facilities supplies are essential for SRH delivery organization and individual to facilitate coordination and implementation of MISP. So, most of the time, like the health workers are, sometimes they are not aware about emergency contraception, or maybe the link workers, ASHA workers. So we have to train minimum things on SRH to all the health workers at the grassroots, for all the grassroots functionaries, about these terminologies, what services are available, where they are available, where they should refer them. It should not become a very delay in taking the decision because they are not aware of these things. So that is how we have to train. That is, training is one more challenge, wherein all the health workers at the grassroots level should have equal knowledge of all these SRH concepts, like what I mentioned in the minimum initial service of 6 objectives. Then plan for the provision of comprehensive reproductive health services integrate into primary health care as soon as possible. So when any disaster happens, if any CSO or any partner, they run and start, responding to the disaster, then immediately they should make sure that comprehensive reproductive health services from the government everywhere it is integrated, because maximum in the disaster we all together can go for 3 months, till it comes to a recovery stage, but later on it should carry on in a very normal manner. So that is why we have to make the integration of primary into primary health care. Then strengthen media advocacy. Media people also should be sensitized how to give the messages or the news to the public. So we should be very even the media should be sensitized properly, the write-ups, how it should come in the media, what should be focused more upon. And one of the biggest challenge is monitoring and evaluation. Regular monitor of effectiveness of intervention to identify and address in service delivery, there is still lack of evidence. So if you see, there are many scenarios, like it may be armed conflict, or it may be natural hazards, disasters like floods, earthquake. So in that landslides, you should make, there are no like very effective interventions available as an evidence base for service delivery. So research also is very important, like how we are monitoring the services, in what situation, what type of services are required in flood, like what is the disturbance caused, and for that, who are the sufferer, who are more vulnerable for that particular disaster, and what SRH interventions when we lay down, how they become efficient, what are the lessons learned. So such monitoring and evaluation should happen in each scenarios, and that should be enough evidence for taking up for the next further, design further disasters. Then security constraints and frequent population movement were frequently reported. See, most of the time in monitoring and evaluation, what happens is like when we are ordering any kits, or when we are ordering any, supply chain management, anything is happening. Most of the time we won't consider the population movement. So once the disaster reduces, when the crisis situations calm down, then again the population movement will be there. All such things like we have to consider while ordering the logistics or whatever it is, or uh, uh, in, allocating the service providers to that particular group. Then one of the other challenge in monitoring evaluation is lack of resources, including a lack of skilled health professionals. So if we go on taking a new health professionals for disasters, those who are not experienced or those who are not trained, that also becomes lot of, it affects the acceptability of SRH services. So they will not be very cultural sensitive in providing services to these people. Monitoring should focus on implementation and sustainability to further contribute as evidence base on which more specific and actionable guidelines, because we are doing lot of services thinking that this may go right or this may go right. So we have to be having an evidence base, uh, things in our hands, so that we can plan more specifically and more actionable guidance can be prepared, and also it can be scaled up very efficiently in further any other disasters happen in any other area. So also we have to build all health facilities to withstand local hazards and ensure that these facilities remain functional to provide SRH services. So already in the local organizations, like suppose if some disaster is happening in Karnataka in one village, that village particular CSO partners, the health facilities, primary health care should be prepared to withstand that local hazards. They should not wait the other people to come and take up these disaster management projects. So that is how we have to build the system of pre-preparedness for this disaster. So these are the main challenges, four challenges which I spoke about is cultural sensitivity, collaboration, coordination, monitoring, evaluation. These are the challenges in providing especially sexual and reproductive health services. So we see the challenges, the one more challenge is logistical challenge. So Krupa asked me to touch upon the logistic challenges in delivering SRH kits and services. So what are these logistics? What do you mean by the supply chain management, and what UNFPA is doing for this? UNFPA, the United Nations Population Fund, responds to emergencies in some of the world's poorest countries. They deliver life-saving sexual and reproductive health supplies and services to protect the rights, safety, and dignity of the women and young people affected by crisis. So for this, they have done kits. So they have named these kits also, like by name, it is universal throughout the nation. Like administration kit is kit number 0, kit 1 means condom, kit 2 is clean delivery. So what all things are required for delivery in that kits, they will be available. And then kit for post-rape treatment, like what is required to collect the smears, all those things. In kit for oral and injectable contraception. In this way, they have designed different kits, and the kits are prepared and kept. And wherever the orders come, the logistics are they are supplying to those disaster-prone areas or disaster areas. So what are these challenges? Like the challenges in delivering SRH kits and services, like intra-agency reproductive health kits are designed to facilitate to displaced populations without medical facilities. So if there are some medical facilities, they are the people who should come in the front line and provide SRH services. So these kits are for those displaced population, or where medical facilities are disrupted during. Suppose if there is a flood and that medical facility has disrupted, there is no electricity supply or anything. So in such conditions, these kits are transferred to these disaster areas. The second thing is the lack of availability of SRS supplies has been documented as one critical gap, impeding the delivery of quality SRH. So immediately, if the SRH supplies are not given, the quality SRH services to the people affected by crisis, we see that this is mostly happening because of pre-positioning, which cause substantial delays. Like example, okay, we have to forecast, or if we don't know the disaster first, we will not do pre-positioning and we wait until the supply comes to us. So that should not happen. That is one of the challenge. Like pre-positioning is one of the biggest challenge which cause substantial, which to avoid these substantial delays. Some of them, and the next challenge is some of the medicines and medical device contained in the kits may not be appropriate for all cultures. So example like, okay, some disaster has taken place in X village or XY village. So you should see the needs of those people. Like not simply ordering all type of kits like ye 10 chahiye, ye 20 chahiye, ye 30 chahiye, aisa nahi. Like you have to see calculate the population, what percentage of pregnant women are there, or like one is the calculation of vulnerable population there, or whether it is LGBTQ prone area, or more sex workers are they are the residents of that area. So you should also be very appropriate in indenting these medicines or medical devices in the kits when you are getting it. This is inevitable as these are standardized. What happens is like UNFPA kits are there, they are standardized emergency kits. So even at our local area, we can use this as a model and prepare our own kits. Like Family Planning Association of India, we NGO, we are located in 40 locations. And according to these kits, we are preparing the kits and we are ready with, like for the nearby area, the kits will be supplied as the demand arises. So we need not wait for the UNFPA SRH kits, and that is what, like otherwise most of the things will go on waste, and which if they are not culturally sensitive. So because they are designed for the worldwide use, it is not specific to Karnataka or Maharashtra or any particular XY village. So they are pre-packed and kept. So we have to think like what are the things we can procure from them and what things we can also be prepared and see that the supply is given there. Then lack of leadership in creating an enabling policy environment to facilitate meeting SRH supply needs before, like during and after crisis, and to ensure more strategic support and continuous commodity availability. So we have to see that like one lead NGO or CSO partner, anybody, they have to see that all the coordination happens properly so that till what time or what type of drugs they are going, medicines they are going to contribute in disaster, and what should come from this X, Y, Z partner. And they have to be prepared and see that this leadership is very effective. Otherwise, we see many times like they think that they will come and do this, and they go on, putting the responsibility on one another, and they escape from that. So there should be a proper leadership existing in delivering these SRH kits. And then integrate humanitarian supply chain consideration for SRH into ongoing health sector development efforts. So every day, our government system is in place, and most of the NGOs who are working in SRH are they are in place. But even during disaster, they should be equally responsible to see that the efforts goes on and that buffer stock is with them for the disaster, at least to see that, make sure that in the 3 months the supply is sufficient in managing the supply chain continuation even during emergencies. Then next is delivering should consider mapping of government policies. So whenever we do delivery of these, supplies, it may be kits or anything, we should see first the government policies. What are the government policies says? What are the regulations related to SRH products? Then storage and transport option, like where we can store, where we can make it as a warehouse so that immediately they can be transported, or data collection tools are available or no, like indenting process, supply chain, supplying, then what is the excess supply, so that it should not go waste. So the data collection tool should be in place, supply chain organization, staff at various levels, and suppliers. So we have to keep ready the suppliers and ask them that in disasters they should be capable enough to immediately send those particular products or commodities, whatever we order for. Then the accumulation of items and medicines which are not needed result in waste. See, most of the time, there is a MISP calculator available, that is minimum initial service package calculator. So if you put the population affected, okay, if you tell there is a landslide and if there are like 3,000 population is affected, so it gives the calculation of how many condoms are required. Then if you tell how if there are 10 pregnant women, so how many delivery kits are required. So all those MISP calculator is there. You have to see that while indenting or getting those supplies, appropriate number of quantities are ordered. Otherwise, it goes in waste, or may become stock out, or you may pile up and many drugs may expire. And rebuild cultural sensitive the local health systems, including supply chains. So it need not be that we always order the kits. We can prepare the kits and be ready according to our area requirement, our so that they will be more culturally sensitive logistic supply. Then transition from acute emergency supply chains to more stable supply chains. That is very important. So once like emergency supply kits are ready, then immediately the disaster goes away, and we most of the time we withdraw all the things. But it should become a stable supply chain later on in the recovery phase also. Otherwise, that will be again take up in a bigger form of disaster. So we have to transit slowly that it becomes from emergency to a stable supply chain. And humanitarian funding structures are flexible to allow for context specific bulk item procurement. So if you see that like more sex workers are there, so some things you need to purchase more in bulk. So you have to be very context specific while purchasing the materials or FP commodities. So, burden global SRH supply chains as overuse in one emergency can result in shortage of another emergency. Simply, they take up so many, kits, and they will not even return them back, or they may use the half of the kit and they are not packed properly. Some are sterilized kits. So, we have to be very sensitive in ordering so that there will be no shortage or in for another emergency area or another emergency occur, if any occurs. Although supplying medicines and medical devices in standard pre-packed kits is convenient, if supplies early in an emergency, specific local needs must be assessed. So don't even we have always think that there is pre-packed kits available, let us order for them. So they might have put like some things which are not required to that specific local need. So we should be very sensitive in ordering the things whether those kits are very essential for this area or no. and accordingly we have to order. Reproductive health supplies need to be pre-positioned by extensive partnership. Very important it is. Like, see, there are many civil society organizations working in all areas, right? In all the district. So we have to identify the partners and see that what are their main work pertaining to reproductive health. So many organizations will be working on some parts of sexual and reproductive health. Maybe some are working on child trafficking, or some are working for HIV, some may be working for STIs. So we have to identify those organizations and partner with them, and we should tell that in disaster, if these things happen, so what are the commodities or you are prepared for? Okay, then next partner what? Some may be giving the transport facilities, or some may give that emergency delivery care. So we have to identify and pre-position. Extensive partnership should be ready, and effective collaboration with even government, local non-profit and donors to heighten the, like maybe Rotary Club of Rotaries may come and tell that we will give the sanitary pads, or we will sponsor menstrual cups for this, for if any disaster happens. So first only we have to be pre-positioned with all these partnerships. Then next is public and private partnerships is required, building local supply chains. So we have to build the local supply chain properly before ordering the kits from outside. So we should see that whatever is available within our local, the resources, first we have to establish a sort of memorandum of understanding, MOU, and see that all together come and they will tackle with these disasters, they will tackle with these SRH issues. And no availability of trained logistics specialists also made us difficult to fulfill gaps in the system and improve transport of vital supplies. Some things like while transportation, it should not damage, or like how much we have to calculate. So we need a trained logistics specialist also to see that, like from where we have to can procure. So what is that, procurement policy we have to take up. All these things are very much essential. Otherwise, it makes us challenging by like more stock or less stock out. So these things may happen. We need to invest on research to generate evidence on what works to improve supply chains. So most we see that there is a lot of research gap in disasters, like how we can improve the supply chains in humanitarian development and all. So we have to invest on, like, if any disaster happens, we should also focus on monitoring, evaluation, studies, research, like what data says, what are the lessons learned, and how we can improve the supply chains in the next, like in if any further disaster happen, and in various disasters also. So armed conflict, your supply chain may be different. If there is a flood, your supply chain may be different. So that is what we have to generate evidence and keep ready, so that any, like FPI, Family Planning Association, is preparing the policies for various disasters, types of disasters. Like armed conflict, we have a policy now we are preparing, and for floods or like landslide. So what, in the stable way, in the stable time, what are the services we are providing, and in disaster, what additional services are required, and who will do this, which are the partners who are contributing for this. So everything in the policy, it has been laid down, so that something is ready in our hand. If any disaster, just we can pick up that policy and accordingly we can start working. So this is how we should be able to understand the challenges and be prepared to see that, to overcome those challenges. So thank you very much. I hope I made it clear, because she had given me 20 minutes time, and I've taken little 3-4 minutes extra, I think. Na, Krupa?
Yes, ma'am,
Hello?
but I think it's fine. They've covered most of the things that we wanted to, including GBV and sexual violence, and you also shared your experience from the field of a child being with POCSO Act and all. And also, thanks for touching upon the human resource development, the training of health workers for being involved in these camps and shelter settings and all. I think our next speaker, thanks for bringing that up, because it's a good transformation to our next speaker, Dr. Paridhi. She will talk about on this as well, because she's an expert in it, along with the research advances in the field. We have a couple of questions from. Can we wait till the Q&A session to attend all those?
Yeah, I'll be waiting. You can
Yes.
carry on.
Okay. Yes. Thank you so much, ma'am. Thanks for your presentation on both the topics, also on logistics. It was very interesting, and thanks for
Actually, yeah,
emphasizing more
actually,
on the pre-positioning of materials in
actually, we have
supplies.
taken up a project on pre-preparation phase now. Like in all the across 40 branches, 10 branches we have picked up, and we are, started with like at the pre-preparedness phase, like how we are training all the stakeholders, multi-stakeholders, the grassroots functionaries, logistics supplies, all these things we are already into it now in the preparedness phase. So this we have taken it as a project, and we are working on this now for sexual and reproductive health.
Yes, that
Yeah.
is very nice to hear, and it's a good time that the session came up and you could share that with us. Thank you
Yeah.
so much, ma'am. And I would like to go to the next speaker, Dr. Paridhi. Yes, Dr. Paridhi, she's an Indian midwife with a doctorate from Uppsala University, Sweden, specializing in quality childbirth care in low resource settings. With over 17 years of experience, she has worked across 17 Indian states to strengthen midwifery education and services through research, advocacy, and interventions. And until 2022, Dr. Jha was a WHO consultant implementing the seven-step action plan for quality midwifery education in Telangana. She has also led action research projects in 5 focus districts on maternal health. She is a distinguished academic and received the President of India's Silver Medal for honesty, integrity, and hard work during her undergrad in Armed Forces Medical College, Pune. He currently serves as a member of the WHO stage subgroup on midwifery policy regulations and environmental, and previously advised for the Ministry of Health and Family Welfare on respectful maternity care and delayed cord lumping. She is also a recipient of the GK Florence Nightingale Foundation Global Leadership Scholarships. And I've heard, very happy to have you here, ma'am. Over to you. Your presentation is visible, ma'am. Please go ahead. Ma'am, can you please unmute yourself? You're muted. You should be able to unmute yourself, ma'am.
I thought I did it together, but all right.
Yes,
I
you're
hope
audible now.
that
Please go ahead.
I do justice to the topic allocated to me, and I would like to start by thanking Sphere for inviting me to this session. I think it's a very important time to look at crisis and SRHR through a single lens because of the very disturbed times that we are going through, as evidenced by the events in the past 3 to 5 years now. And yeah, my name is Paridhi, and I would like to take you through a few of the insights that come from research advances and what kind of way forward has been proposed by the research evidence that has been generated around SRHR in crisis or disaster management, rather. What you see now on your screen is the regional strategic framework for accelerating universal access to sexual and reproductive health in Southeast Asia. And as you can see, the sexual and reproductive health and rights, they remain at the center for nearly all the policies nationally and globally because of the huge impact they have on the sustainable development goals. Here we have listed the 4 key ones that they most prominently touch upon. One is good health and well-being that cannot go without addressing the sexual and reproductive health and rights very unanimously. We have gender equality because we know the access to the SRHR and even SRHR itself at its core is extremely gender and power driven because of the socio-cultural context, sometimes political context, and sometimes it could just be the stigma or the taboos that accompany these conversations. Then we have also another sustainable development goal number 10, which is reducing inequalities. And as previous speakers have also highlighted, by the nature of being sexual and reproductive health beneficiaries, the whole group usually gets unequal treatment. It can be socio-economical, it can also be normalizing poor services, poor health around SRHR globally or locally. Then the partnership development for attainments of the goals. Obviously, SRHR is a huge area, and it is not a cup of tea for a single individual institution. Usually, a group of like-minded people have to come together to drive the motion forward. And as you can see in this particular slide, the strategic outcomes, nearly everywhere you can see that the SRH services in humanitarian crisis are predominantly mentioned. So, one thing we can clearly say is that whatever the situation we are in today, and whatever gaps that we have in terms of incorporating SRHR into the system, we still can say that there is a better improvement now, because at least in the global and policy level, these things are getting recognized and are gaining more traction with the right type of crowd. Now, disasters and access to SRHR. This is a very messy diagram that I have put together, looking into different evidence articles that have mentioned different aspects of management of SRHR during disasters. And first and foremost, I think we must understand the nature of disasters, and I think we have all had our initial education has prepared us that there can be two types of disasters. They can be natural or man-made, and the natural disasters are no longer now limited only to calamities. Climate change and environmental issues have emerged as a global disaster, which is so slowly advancing that we most of the time don't even acknowledge or feel the gradual shift towards more dire environmental issues now. Then, presence of pandemics and epidemics. No one needs a second note on that. We have very recently gone through a pandemic. We are still struggling. Economy, health, any system you pick up, it has left a tremendous impact. And then there are man-made disasters, which are war and terrorisms. And then there can also be huge accidents or huge unforeseen events that may be resulting into a disaster of a new kind. And all of these uh, events ultimately uh, bring out the three delays at the forefront again. So, the moment you are living in a crisis, there is it's a very very natural tendency for people to normalize whatever is the ongoing health issues that they have. And SRHR, it is most predominantly visible when you look at the ANC, PNC, neonatal care, adolescent health. It can be mental health issues. It could be your HIV, AIDS, access to family planning. So you name any one. These are all normal life events. In many ways, people are living with those chronic diseases or chronic events in their life. They are living with a normal physiological process like childbirth and maternal role transition. So they tend to normalize everything and say, okay, we will go once the situation is more stable, and we may miss out on the key signs when they are actually supposed to move out and seek care actively. Then the reaching of the facilities, this is another challenge, and it is a two-faced challenge actually. One, whether the facility is still functional. Second, if this facility is functional, whether it is the pathways to reach that are still accessible. And then once you have reached there, the third delay, which is receiving care at the facilities, when we know that in a country like India, everything is already overburdened, overworked people, and now you bring in a disaster, then automatically the shift goes into the triaging of events, and very naturally, and somewhat because of the socio-cultural context drives us, so the regular care provision gets disrupted, and this we have witnessed during COVID times very recently again. And then all these three delays ultimately impact the different levels of disaster, which arises from preparedness to response to recovery to mitigation. And I have put a ecological model framework in the center of it because I find it the most easy way to quickly thematically look at different aspects that are ultimately causing the problems, or where the interventions are required. So, in this crisis cycle, if you put the or contextualize the SRHR into the context uh, of disaster, you will see that there is a need for interventions at individual capacity, at organizational capacity, inter-organizational capacity, at sector level capacity, and at national capacity to ensure that once a disaster hits, these services are able to continue without having to face unnecessary major disruptions for long periods of time. uh, the components I have listed and why I have brought out this particular framework by WHO and UNFPA on components of SRHR is that SRHR is not merely limited to very few services that we have touched upon, but there are a total of 9 components, including the education, including the well-being, general well-being and health, including infertility. These are areas that are probably not thought about first, even when we are talking about SRHR, which is generally governed by talks around the 5 topics, and I have ranked them. Please note this rank is not allocated by any agency. This is my own interpretation of the assigned importance or assigned importance to the perceived impact of particular components that the society will face in the long term if they are left untreated. And this I have been able to pick based on how different Cochrane reviews or different policy documents rank them when they are addressing the different components of SRHR. So the top 5, as you can see, starting with the the maternity, I think it ranks first because it's not one life but two that we are talking about. Moves on to the safe abortion, post-abortion care, because of the imminent life risk if the case is not handled properly. Sexually transmitted infection, including HIV, again for the same reasons and the associated serious comorbidities, and then the cancers of the reproductive system, and family planning and contraception. Family planning and contraception, I guess, lags behind only because at least it doesn't cause immediate threat to life of an individual, not because it ranks lesser compared to other components. So, different global Cochrane reviews, the way they have addressed or listed the interventions, I could just pick out a few interventions that sounded very interesting at different capacities. At individual capacities, if we want to improve the SRHR management during crisis, most of the Cochrane reviews have highlighted having to sensitize and build the capacity of the community, of the individuals, and of the healthcare providers per se to ensure that the crises are managed properly. They advocate for a strong support system like a crisis response group where you identify the key influencers and decision makers who are able to lead their communities on the right path during a crisis and can be the go to person even for regular services like SRHR that are hugely disrupted. And then inclusivity of vulnerable groups. I'm not going to go into details as previous participants have already covered it really well. Organizational capacity mostly surrounds availability of supply and manpower, conducting the preparedness drills, undertaking different scenarios that are most likely to affect a given facility and surrounding community, and then ensuring that the minimum initial service packages are made available. uh, Again, I'm not going into detail because we have touched upon the topic already. I didn't really see a lot on inter-organizational capacity, except that we improve the coordination between different players to ensure a smooth transition to services and smooth functioning at the time of your, how should I put it, the referral systems become better. So, keeping that in mind, we move on to the sector level capacity development. And here, the importance has been given to reduction of the vulnerability at the at risk population before an emergency actually happens. Provide the basis for scaling up measures to meet wide ranging health needs, utilizing the opportunities in the recovery phase to strengthen services and reduce risk for future events. So these are the few innovative ideas that I could glean from the published work across the world. And then the national capacity building usually talks about initiatives. And one initiative which is very frequently mentioned, supplied by or funded by the Australian aid, is sexual and reproductive health in crisis and post crisis situation, called as the Sprint Initiative. And it is driven in countries that are listed in the blue box. You can see India is one of them, and most of these countries you will see they are it sounds more likely the initiative for the disaster and natural disaster uh, crisis. But there can be other crises, and there can be similar groups formed that are in line with this particular. Now, after going through a very rapid scoping of these documents, I could very confidently say that in terms of gaps in evidence, there are too many to count actually, because a very little work has been done around improving SRHR during disasters. There are a few interventions, as I have shown in the last few slides, but in no way they cover the whole spectrum of interventions that are needed at different system levels to ensure SRHR services go undisrupted even during crisis. So, the few gaps that come out in strategic directions and in policy documents are identifying interventions to prioritize SRHR during disasters, and it needs to be done at community health system and policy level, developing and testing action plans. And these developing and testing action plans have to be done after contextualizing them to ensure they are detailed, concrete, and evidence based. And then we have to support implementation, operation, research around SRHR management in disasters, capacity building of care providers, disaster response groups from the communities. We need innovative and automated mechanisms to improve supply of family planning and wash supplies, for example. And then we have to incorporate the lived experiences of different stakeholders, incorporate the lessons learned, and participatory approach needs to be taken to develop the action plan. Ultimately, the costing of the SRHR services, and the previous speaker has also given a very good example of how the costing needs to be done. This will be very helpful in actually ensuring that the action plan that is developed is ultimately implementable. So, thank you so much for taking you on a for this opportunity to take you on this roller coaster ride of research during evidence. I hope you could understand some of it, if not all of it. Over to you, Krupa.
Ma'am, thank you so much for the extensive presentation. There was one particular slide that I found very interesting about the UNFPA framework and how you had ranked it. I was about to ask you to explain a little more on it, and you yourself did the explanation. It's very interesting how, from your experience, you could rank the components based on the importance and priorities. Thank you so much, ma'am. And okay, we do have time for Q&As. There is a couple of questions on the Q&A I would like to ask first. Uh,
Sure. I would
Sujata
like
ma'am,
to stay
yes,
away, stay back for 2 minutes, and then I can join back.
okay. Is there any questions? Participants can unmute yourself and ask your questions. Okay, before that happens, there is a question towards Sujata ma'am. Ma'am, there was a person that asked a question while you were talking about the cultural sensitivities involved in culture in camp setups. Somebody has asked you to convey your real life experience from your field experience in the camp, real life experience, and how you faced the challenge and how you resolved it.
Yeah, when it comes to LGBTQ, when the people were allowed for the camp settings, first, they prioritized men to go move in, then women, then they gave the chance for the children, and the last was like the place if remaining for LGBTQ. So that was the experience we felt. So how they discriminated and all, and also like to become like cultural sensitivity when we went with the condoms, to supply in these camp settings. Also, like the police, the advocates, and all, these were the people like felt they took it in a very easy way and they laughed like, see, there is no time like to have them proper food, shelter, and clothing, and you are thinking of the sex now. So these are the things. But when in the post crisis, when the figures boomed up with this unsafe abortions, with ART supply, with HIV, young people rate increased to HIV, incidents. So that time, these stakeholders or these, functionaries realized the importance of these SRH commodity supply, LGBTQ, like why it is necessary for them, and they were stigmatized. That is how, like, we took. So that is why before in hand we have to be prepared, like where they will be placed in the camp setting so that they are not stigmatized or discriminated. So the pre-preparedness is very important, and that is what we have experienced.
Yes, thank you for that, ma'am. Also talking about the evidence and what you were talking about, the figures moving after
Your voice is
the
not clear,
crisis is
Krupal.
over, and then we go back. Yes. So talking about all these, I would like to ask the next question also to you, ma'am. The question was about GBV, gender-based violence, and is there any data or evidence that is increasing in disaster setups?
So if you see the GBV, the reporting of the GBV is really not at all like is coming into light. So we see that GBVs are not reported properly. That is what early warning system we are being creating now. So very few GBVs like we could see when the clients came to the facilities reporting on unsafe abortions or with sexually transmitted infections, but those were the data available. But exact GBV, how many domestic violence happened, gender-based violence happened, the reported cases are not properly, like that database is not yet found. So only at the facility level, the data is available about this GBV. But we see that 1 in 5 women, they face the lot of research data and all, they show the data in this way that 1 in 5 women face GBV. That is what the figures come out. So based on that, we are doing the preparedness phase now. We are into that.
Ma'am, I have a question. If you, ma'am,
Yes, you
if
can please
in
ask the
for
question.
yeah, thank you. Ma'am, if someone wants to collaborate with you regarding for future research projects, mainly in the SRH, so ma'am, can we approach you? I mean, Are there opportunities to collaborate with you, ma'am?
Yeah, for trainings and all, we are fine. We are okay with it. Like if you want for our with us the collaboration for trainings, or you want to establish MOU for in near to our nearby location, like to work with during these disasters, we welcome here and we are okay with it.
Ma'am, is there any satellite center of your organization in Delhi or in
In
Delhi NCR? Ma'am,
where?
is there
In
any
NCR.
is there in Delhi NCR, ma'am, is there any satellite center of your organization, ma'am?
Delhi.
Yes, ma'am.
Yeah, Delhi we have FPI. I'll share you the address with Krupa and she will share that. Otherwise, I can share you the address of Delhi.
Okay, thank you so much, ma'am.
It's happy to see how the session is opening doors for more collaborations.
Yeah.
More questions are welcome. Other participants, if you have any questions. So I think that is it. And if there are any questions, I will definitely be the bridge in conveying it to you to the experts. The PPTs of that the experts use will be circulated in the through mail to your registered email ID. Thank you so much. Thank you, Paridhi ma'am. Thank you, Sujata ma'am. Thank you to Shilpi ma'am as well. She's not here with us right now. And thank you for taking your time out and talking to us and answering our questions patiently. And thank you for being very extensive and very detailed in your presentations. And a couple of things were very interesting, and I admire how perspectives change with different expertise. It's very nice to see that, and how logistical challenges can be addressed. I'm happy that we got a lot of strategic insights from the experts, and I hope we can build upon these and more collaborations to come. There were a lot of appreciation from the participants on the session being informative and the experts being very kind about their presentations. Thank you so much for that, ma'am. And yes, consider this as my vote of thanks to all the participants as well for your active participation, for all your questions, for all your interactions. And, hopefully, we can get back with you all in another session in a much more interesting topic, and these panel can be brought together again. Another all-female panel. It's going to be, I don't know how long it's going to take for us to have that in Sphere India Academy. Anyway, thank you so much. Thank you, everyone. Hope you have a good rest of your day.
Thank you. Thank you.